Hi, good evening, everyone. Thank you for joining us in person and at home. We're very excited to have this festive Clinica Academy Christmas quiz, and it's the glaucoma edition. I'm Miss Lisa Jagan, and I'm an ophthalmologist and oculoplastic surgeon at Clinica London, and I'm hosting this evening. We're very, very privileged to be joined by three expert glaucoma consultants. So we have Professor Anthony Khawaja, Miss Emma Jones, and Mr. Minak Bhalla. And we're very excited because this is meant to be an interactive session. So please do ask questions and chime in on the chat because we want this to be as discussion-based as possible. That's really all that I have to say. We're very excited to have you join us, and we're going to take turns presenting cases, but again, meant to be just a nice, fun, big discussion. So we'll start with Mr. Minak Bhalla. Thank you.
Brilliant. Thanks, Lisa. And it's a privilege to be here to give a talk about glaucoma, especially with a Christmas theme to it. And I'll be presenting some cases along with Anthony and Emma. So I'll start off. So for my talk, I'll be giving you an overview of interpreting OCTs really, and then looking at some differential diagnoses, what to look out for OCTs, and I'll briefly touch upon a case which I saw here at Clinica and why I ended up doing laser, and I will briefly touch upon some research guidelines as well. So what we know is that, well, OCTs, optical coherence tomography, is an excellent diagnostic tool that we use in glaucoma. And it gives us an objective overview when retinal nerve fiber layer is being thinned. It also gives us an idea of whether the neuroretinal rim is changing as well. It's based on a scan, that's a circular scan that's done around the optic nerve. And the reason it's circular really is because that's where the thickest RNFL is, which is the retinal nerve fiber layer. And this has been standard for OCTs for many years, and it's also been standard for the normative database that the OCT holds. So it helps us compare our results with those that the machine has had in the past. And the beauty of actually doing an OCT disc is that it basically gives us an idea of whether there's any glaucoma. And more importantly, for those patients where we're a little uncertain whether glaucoma is developing or not, it gives us a subtle indication of any early change, which can be key of whether you want to bring the patient back sooner or whether you even want to start intervention as early as possible. Now, OCT can also assess the macula as well, and that can actually be quite important for glaucoma. Reason being is that the macula has many layers of ganglion nerve fibers, 7 to 9, and these layers, if there's subtle changes there, we can pick them up on the macular OCT scan, and that can be through either a ganglion cell or in a plexiform layer. Whereas when the retinal nerve fibers all go into the optic nerve, they bundle together. So sometimes you can't really pick up the early changes. But the most important thing to realize is they're not two competing scans. You want to use both pieces of information together when you're making your clinical judgment. But the macular scans are equally very important. So I'm sure I've been guilty of this, but when we look at OCT scans, we really are drawn to the colors, and we can see green and we can deem them to be important, like actually normal. And if they're red, we deem them to be abnormal. But that's not always the case. And that was one of the key points I really wanted to get across before I presented some cases. So if it's a red scan, just remember that's not always glaucoma, and that can be due to a number of reasons. It could be due to the disc itself, if they're high myopes or they're tilted, or it could be due to the quality of the scan. Was the circle scan the same as previously? Is there some form of a pacification either at the cornea or even as a cataract where the signal that's being transmitted by the OCT isn't being returned at a good strength? So you have to consider all of those things before you deem a red scan as an abnormal scan. And similarly, when you look at a green scan, don't always assume that's normal as well. And like I said before, well, that could always be due to actual disc pathology. So if you have drusen, for example, on the optic nerve, you can get this false impression that's normal when it actually isn't the case. And when you're looking at these scans as well, just remember the normative database that these scans are built on. And a lot of them are based on Western demographics. And, in London in particular, we have patients of all ethnicities, so we should always consider that. The floor effect is quite important to understand. So patients who in particular have advanced glaucoma, and you're looking to see if they're progressing or not, once they reach a certain level of thinness, you may not be able to identify whether it's getting worse or not, and that's because of the floor effect. So it's always important when you're looking at the OCT scan to take information from the visual fields from your actual examination as well. So that kind of takes me nicely on to how to read an OCT scan as well. Now, some of the steps that I use, I kind of summarized here. But what's really important to understand is that when you have a piece of diagnostic information in front of you, we should always remember to make sure that it's the correct patient. So make sure that the patient that you have matches your visual field patient and matches your electronic records as well. Once you're pretty sure of that, make sure you check the quality of the scan, and that sort of reflects upon the signal strength. Make sure everything's centered, it's similar to previous. Then you can go on to the retinal nerve fiber thickness map as well, which is demonstrated here in that image. So often when you have darker colors like red, that means there's higher levels of thickness. And when it's thinner, which is closer to blue, that means there's obviously thinning. And you can see from this example that you could potentially say that actually the superior part is a little bit thinner than the inferior. You can then go on to looking at the TSNIT profile. And what that really just stands for is temporal, superior, nasal, inferior, and temporal. And you look at this by looking at that line scan there. So you're looking at for that double hump, and the double hump is quite important because you're looking at both the superior and the inferior parts. And these are usually the parts that get impacted first in majority of the cases. So following that line scan and making sure that one, it follows that sort of pattern, and number two, if there's any focal dips anywhere. And as I mentioned before, you then obviously use this information along with the GCL, the ganglion cell layer, and the inner plexiform layer map, which is the macular scan, and see if the defects are matching those of the other scan as well. So like I said, combine the two to help you get a better idea clinically of what's going on. And if you're lucky and you have the BMO available, which is known as a Brooks membrane opening, this is a particularly good scan because it can identify or actually mitigate against patients who have slightly unusual discs. By looking at the anatomical variation, it can basically prevent you from misinterpreting scans that may be deemed red. Because if you use the BMO scan, it will hopefully, like I said, take into point if the scan's myopic or tilted, it'll measure anatomically the correct rim measurement. If your practice has the progression analysis, you can actually use that and compare all your previous scans as well. Now, I, in my NHS practice, use Forum, Zeiss Forum, and that very nicely actually collates all the previous scans along with the visual field, so you can compare all sets of diagnostic tests and compare them one after the other. So I now bring you on to some of the cases. So this first case was someone that was brought into our diagnostic clinic in my NHS practice, and it was a 48-year-old who presented with headaches, no other ocular symptoms, no past ocular history, and no other past medical history as well. So this is what I identified. I saw this on the testing in my virtual clinic. So what would everyone do? Is there any particular approach you would take when you see something like this presented to you?
As it's binocular and it looks like a quadranopia, I think it's called. And so it must be affecting both nerve fibers towards behind the chasm.
Yeah.
So I'd refer.
Yeah, right. And that's pretty much it. It's pretty you pointed out exactly correctly. So any sort of defect that's affecting, the vertical meridian, one, it raises a lot of concern that are we dealing with something that's not ocular, but rather neurosurgical? And as soon as we see that, actually, if you're in the community, you should be referring in. And if you're in hospital, then you should be thinking about scanning. And this case is primarily to highlight that. Now, the other reason I brought this case on was because I wanted to show you that actually the same rule applies when you're looking at your ganglion cell layer map as well. And I remember being at a talk at one of the Moorfield glaucoma conferences where they invited a neuro-ophthalmologist from the US called Andrew Lee. And he basically pointed this out, that actually when you don't have a visual field defect as obvious as this, but you're seeing some changes on the macular scan, which is respecting the vertical meridian, and there's a clinical history that may suggest something else is going on, then you should be thinking about scanning further or doing at least further investigation. So that's really important. And that was really the main reason behind this scan. So this was another virtual example as well, where a patient was referred from an optometrist and they had seen a potential visual field defect, and they were worried whether this was early glaucoma. It was a 32-year-old, a high myope, and with no other ocular history, no past medical history, no family history either. And they had just gone for a routine test to their optician. So what would everyone do in this case?
There's not much loss of nerve fibers there. It's a very tilted disc. Well, it appears to be tilted, and so I think it's just watch this space.
Yeah. And that's one of the reasons I really put this up, because actually a lot of the time we do get a lot of myopic patients coming in. And the real reason I'm showcasing this particular example is so that trying to raise awareness that we don't intervene prematurely. So patients who do have a tilted disc, often these patients have an optic nerve that comes into the globe infranasally, and sometimes they can have this arcuate defect that can come about. And actually, there's usually a couple of reasons that this can happen. Number one, they can have just a refractive element. So because of the tilt, the focus of light is just before where the retinal nerve fiber is, so it can be blurred. And the way we can identify this is by perhaps adjusting the lens that the technicians are using for the visual fields, and getting the correct lens can actually take this away. Another reason this could happen is sometimes patients have something called tilted disc syndrome. And what that means is, again, they are born with this, oblique insertion of the optic nerve into the globe, and they can get a bit of hyperplasia, so a maldevelopment of the retinal nerve fiber layer. And those patients, obviously, the lens doesn't adjust for it, but what you will find in those cases is that nothing changes over time. So to observe those patients, as you correctly said, would be the right thing to do. And as long as that arcuate's not changing, then perhaps this is something they have been born with. So that's just something to keep in mind.
We have lots and lots of these in our virtual clinics.
Yeah.
Oh, sorry. So there's no harm in sort of referring them in. We have lots and lots of these sorts of patients in our virtual clinics. I suppose it's just the expectation when they get referred in that you're telling them that, you're just doing it as a precaution.
Yeah, that's a great point, Emma. Yeah, exactly. So it shouldn't stop you from referring these patients in, but we would obviously go and monitor them, but it's just about, I guess, those that do hospital medicine to make sure that we don't, jump the gun and start treating them straight away, and to make sure that if it is stable, we can happily watch them. And this is my final case, actually. And this was a lady who I saw here at Clinica. So she was a lady who had wasn't getting an appointment in a timely manner at the NHS. So she had booked an appointment with us. And she had been referred to see an ophthalmologist about narrow angles, which had led her to be quite concerned after she did a bit of research on Dr. Google. She was otherwise asymptomatic, and she had a past medical history of being treated for breast CA. She'd also been screened previously for a retinal nevi, and was just going to her local optometrist to have that reviewed. No family history, and very interestingly, on her social history, she was an ecologist. So as an ecologist, she was going around the world and actually spending long lengths of time in very remote places as part of her work. And I found that history quite interesting, especially as she had been referred as a narrow angle case. So when I examined her, it was a fairly unremarkable anterior segment examination, but on gonioscopy, I did find her that she was closed more than 180 degrees. Normal optic nerves, normal other diagnostics, which were these. So you can see by the anterior segment OCT, she was quite closed up. But as you can see by the OCT of the optic nerve, it all looked very healthy. So what would people do in this instance?
I would prefer in this case, because the ladies working in remote places, that's a definite referral.
Yeah, fantastic. That's,
Yeah,
that,
that's
yeah.
it.
And that's absolutely right. So that's
And wait, a minute before you go to the next one, I just want to ask if Emma or Anthony has any thoughts if they were seeing this patient.
Yeah, so like Minak is, as you said, oh, sorry, couldn't jump again. As you said, you obviously know what the PAX Plus features are, and you've correctly spotted because they were working in a remote place that they've got plus features. And it's only recently that like the risk stratification for primary angle closure that we have guidelines on that. So it's very good that you know that.
Yeah.
Anthony.
I mean, the laser iridotomy I did last was for a patient who was going on holiday to the Antarctica. So, I mean, I think it definitely is a consideration. But of course, it's still a discussion. Everything is risk and benefit. And some patients, despite spending time in remote areas, might choose to not have an iridotomy. The chances of that person going into angle closure is still very low. But it's just that if they did and they were in a remote area, that would be bad. The other things I take into account, if that patient had a really thick brown iris, that might get inflamed, or there might be more chance of a complication after a laser. Maybe I'd lean less towards doing it than someone who's got a thin blue iris where you know it's just going to be a couple shots on the laser and you're through and they're very unlikely to get inflammation or something. So I think it's always a case-by-case basis. It's never there's one right answer for anything. I think we'd all agree with that.
Thank you. That's great.
Absolutely. So both Emma and Anthony have said basically what I was going to say. Whoopsie. I'll just go back. No. It's great. Actually, one of the things I did was I had a honest discussion with her, and I told her, look, our practice has changed. So during my residency, we did do a lot of peripheral iridotomies on many patients who were primary angle closure. And in recent years, that had changed. And it was primarily because of the ZAP study. So the ZAP study showed that patients who were the highest risk, these were Far East Asian patients, when they actually did laser in one eye and kept the other eye as control, it did reduce the risk reduction by about 47%, but actually the chance of them developing an angle closure attack was so little that it actually changed our approach. And so the guidance that I've cut and pasted onto this slide is actually from the Royal College. So we only offer peripheral iridotomies on a select number of patients, and those that fit this criteria, the PAX Plus criteria. And I've circled why I discussed the possibility of her having laser, and it was basically that last bullet point, that if patients do have, they live in a remote place, so if they are working in Antarctica, or are, they're an ecologist, or they work on an oil rig in the North Sea, then these patients may not be able to get the help they need in a timely manner, even though the risk is very small. So offering them that laser treatment is very reasonable. And when I presented these facts, and luckily the patient did have blue eyes, it was very easy to laser. So she was quite keen to go ahead. And that was actually a fairly routine laser procedure. And the patient is away at the moment, but when she returns, she'll be seeing me again, and then we'll just follow up from there. So those were sort of a summary of cases that I wanted to highlight in relation to our sort of Christmas-themed glaucoma presentation. So hopefully from this, we've learned a little bit about how to interpret, a quick overview of how to interpret an OCT. It wasn't that detailed, but a quick overview. And just remember to always be systematic in how you review the scans. And it always has to be in relation to all the other tests that you have in front of you. So your visual fields, your OCTs, and actually also your history taking as well as your own examination. So we can't, in ophthalmology, we're very blessed that we have a lot of up-to-date, fancy tests that we can do that can give us a lot of information. But as a traditionalist, it's always good to make sure that you have a thorough history and you find out everything and do a good examination and use that with the test you have to make your clinical diagnosis. And just remember that not everyone needs a PI. Thank you. Yeah, of course.
Just a question about the last case.
Yeah.
So if you decided not to do anything? How soon would you review them again?
Yeah.
Say if they were based in London or yeah.
That's a great question as well. So for someone like that, so number one, I would always tell them sort of the red flag symptoms of what to look out for, should they have any sort of symptoms, and how quickly to seek help. So I wouldn't really want anyone to sit around on symptoms of pain, visual reduction. In terms of follow-up, to be honest with you, I would probably not follow them up that frequently. I would probably give them one further follow-up in 6 months, and then I would even say whatever they're comfortable with. If they're happy to see the optometrist on a yearly basis, they can do that. If they're happy to come to the diagnostic center, I would give them a couple of visits there. But as long as they're aware of the risk and what to look out for, that's how I would approach that.
Would you recommend that for us optometrists as well, to review them like maybe once every 6 months or annually?
I think if they're at high risk, I think referring them in is absolutely good, but an annual review is very sensible.
Thank you.
This one, we've written at Moorfields Eye Hospital, and it's downloadable, and a leaflet on narrow angles, which is if a patient's been identified with narrow angles but they don't have laser, and so it explains what to look out for. And things in the future, for example, if you're going to start certain medications, which are anticholinergic, which can trip people who've got narrow angles into angle closure, it's got a list of them on there. So it's a useful leaflet that you can give. But I agree, annually with the local optometrist. I don't think we've got space to see the huge numbers of people with narrow angles otherwise. Oh, do you like that?
Thank you, Minak. That was very, very good. Very interesting. I just want to encourage those who are at home, please do feel free to chime in the question and answer section online, because we'd love to hear from you. But now we'll put it over to Anthony.
Okay, thank you. Just to say, I do consult for Heidelberg Engineering and Topcon, who make OCT devices. So the first case, I've got a couple cases, and then a sort of a more general presentation about pre-parametric glaucoma. So this is a young man who was complaining of tired eyes when he went to his optometrist. He's a -4 diopter myope, and was referred to me for a reason that I won't say, otherwise it would ruin the quiz. But he also had high pressures, and when I saw him, his pressures, we used the ocular response analyzer at Clinica. His pressures were 29.1 and 23.9 millimeters of mercury, but he had full fields and he had normal discs, all of those things Minak talked about, the Brooks membrane opening minimum rim width, the circumpapillary retinal nerve fiber layer, and the ganglion cell layer were all normal. But these were his anterior segment OCTs. So would anyone like to say what the diagnosis is on the basis of those anterior segment OCTs?
Corneal thickness here.
Just repeat that again.
Corneal thickness would be.
I think it was average. I can't
Average.
remember, but it wasn't really relevant.
Right, okay.
So just on the basis of what you can see there, does anyone have an idea of the diagnosis?
It seems that all the aqueous is being trapped in the anterior chamber and is bowing the iris.
Iris backwards.
So it lets out
So what is
liquid.
that called?
It's just not draining. The trabecular meshwork might be blocked.
Blocked with what?
PX or something like that. Oh,
With pigment.
pigments.
Pigment dispersion syndrome. So this is what pigment dispersion syndrome looks like on an anterior segment OCT. The iris bows backwards, and that's why it rubs and releases pigment. I didn't quite understand this, actually. For years, they talked about reverse pupil block, and I said, but how does that happen? Because the fluid's made behind the iris and then goes through and then goes in front. So how can the iris bow backwards? And it's interesting, it's an anatomical thing. And when these people, often myopes, like he's a -4 diopter myope, every time they blink, fluid from behind the iris gets bulk pushed into the anterior chamber, and then the iris blocks it again against the lens. And so you get the aqueous build up in front and it pushes the iris backwards, and then that's why it rubs. So what could you do to relieve that differential in pressure between the front of the iris and behind it to straighten out the iris. A laser iridotomy, a little hole can straighten it. And so that's becoming really an emerging treatment for pigment dispersion syndrome. You all know what pigment dispersion syndrome is. So that bit that's bowing backwards rubs, and over time it becomes translucent, which is why you get the iris translumination. The pigment goes on the cornea, and that's the Krukenberg's building, but it also builds up in the angle, and you can look at that dense piece, like literally caked in pigment. So no wonder they end up getting high pressure. And then you can do an iridotomy. Emma, will you be talking about the position of iridotomies?
No, I'm not talking about much. So you can.
Okay. Well, just to say, we used to do them at the top, but actually it's when the tear meniscus does a prismatic effect, that's when people get all of the funny symptoms. Whereas if you do it in the side, when it's not covered by the lid at all, they're much less likely to. So that's why we've moved to doing the iridotomies at 3 or 9 o'clock now. They're much less likely to get the... Okay. Sometimes they'll see a line in their vision, or vertical or horizontal, or aware of glare, or just visual disruption. So a range of symptoms, but actually I rarely hear it now since we've moved to doing the laser on the side.
It's a bit controversial, that paper, because it was quite small. Anyway.
In my clinical practice, since moving it to the side, I very rarely get patients who have a problem, and we think it's because of this prismatic effect. But anyway, there you go. Can you see which iris had was it the right or left iris that I first did the laser iridotomy on? The left, yes. So you can see, well, one, it's not bowing back anymore. It's now flat, and you can actually see the iridotomy there on the right-hand side of it. You can see where the hole's been made. But there you go. You've reversed now. That patient's not going to be shedding any more pigment. So that's a really nice treatment for pigment dispersion. This paper was quite nice. They had 15 years follow-up for lots of people that had this laser, and that's how the pigment starts off, really caked on. It takes a long time to go away, so don't expect any miraculous changes. So it's been thought that this is the pigmentation going down over time. But when you do, pigment dispersion is not common enough for them to do big randomized trials, and so the trials haven't really shown much difference. But the problem is you're not going to get anything immediate. So if you've got someone with pigment dispersion syndrome, but the pressure hasn't gone up yet, that's thought to be the best time to do it, because then it won't go up due to pigment dispersion, because you won't get any more. If you've already got it, it might take too long for the treatment to actually, for you to notice an effect, because it takes a long time for the pigment to go. But when you see that anatomy, I think it's a no-brainer that you can reverse that cause of the pigmentation. Okay, so that was one case, pigment dispersion, and I've seen like a trend now towards, I think as we've been getting better and better anterior segment OCTs, people have been more and more convinced that that's a right thing to do, to just totally reverse that reverse bowing. It's
even without any symptoms of the pressure being normal, or even.
Sorry, I'm just going to repeat the question.
So as optometrists, whenever we see patients with PDS,
yeah,
without any symptoms, normal pressures, everything's normal, but we see these pigments on the anterior surface, do we refer them all routinely?
Well, I think they should be offered laser iridotomy. There isn't international guidance on that. I don't think NICE provide any guidance. But,
no,
but I mean, if I was that patient, I'd have a laser iridotomy.
Yeah, but ophthalmologists will not be upset if we refer them all.
Some might.
Some might. Yeah, that's what I was going to say. Okay, so that's very useful.
We mind. Would you mind? Do you mind? No.
Okay.
Okay.
Okay. Thank you very much. Thank you.
So send them to Clinica London. Yeah.
Sorry. There's a couple of patients on a very old treatment for it, which was pilocarpine. So one of the few, like pilocarpine is like a bit of a dinosaur medication that we use for doing procedures, but not often to treat patients. But occasionally there are some patients on dilute pilocarpine because it constricts the pupil, so it's supposed to be less bowing, but not really used that much anymore. Yeah.
Hiding the symptoms. That's hiding the problem.
Yeah, indeed. Yeah.
So this patient's somebody who's being monitored as a glaucoma suspect, and just a suspect. The fields aren't that bad. She just can't do visual fields, basically. So that's out of the equation. So we're relying on just OCT, which is good because then it means we have to look carefully at the OCT. That doesn't look so bad there, and we could follow up the circumpapillary retinal nerve fiber layer. And what do you think of the macula there then?
I'm going to interrupt you, and actually there's a question on the chat to go back to the first case.
Yeah.
Did you do anything for the high IOP in the first case, or was the iridotomy enough?
The iridotomy definitely wasn't enough because we don't expect a quick effect. So the patient's on drops, and if I've got time, I don't want to overspend my time. I've got stuff on showing that, but somebody like that, I'm monitoring his OCT. There's almost no point in monitoring his visual field because you won't see anything. But if you've got a good OCT, and really the best in class is the Heidelberg Spectralis for this because of the registration it does, then you can monitor for change. And so his pressure now in the eye that was higher is around 22. So you might think, well, is that low enough? Well, actually, so far it has been, and I'm confident he's stable with very nice OCT scans.
Thank you.
So on this one, I mean, I think, you know, what's going on at the macula there. And one real downside of these sectors is that they're designed not really for any other condition other than glaucoma. And so this is a take home, and it's same with Minak's patient. You have to look at the map rather than just the sectors. So now when you look at the map and you look at the pattern there, what do you think is going on with this patient?
Neurological.
And yeah,
That is neurological.
because it's
Yes.
respecting the
Yeah.
vertical meridian.
Yeah.
It's going so when something seems to affect one bit and then just really respects that vertical line going through the middle, and it's in both sides, that makes you think of something neurological. And this patient actually has myeloma, and they're known to have lesions in their skull, but they weren't known that the lesions were actually affecting probably the visual cortex at the back of the eye. So really Minak's covered this already, but a take-home point, macular scan, but also, look, those sectors, there isn't a sector either side of the vertical meridian. You can't see whether something's respecting the vertical meridian just from the sectors. You have to look at the map. And this is the last little bit, a talk that I was asked to give at a meeting by EssilorLuxottica, who have recently bought Heidelberg Engineering. And luckily, they seem to want good things for because the size of Essilor versus the size of Heidelberg, we're worried that we'll lose Heidelberg Engineering, but it's looking good. But anyway, what does pre-parametric glaucoma mean? This is a graph popularized by Bob Weinreb from the United States, showing the whole spectrum of glaucoma, and it's this early stage before we can see a visual field defect, before a patient notices anything, but before we can even measure a functional problem. But of course we care about it because, you know, anybody who's ended up blind from glaucoma started off with glaucoma at that bit. I put this in just as an analogy. I had a coronary angiogram. It turned out not because I had a blocked heart vessel. I actually had a myocarditis, but they told me I had mild coronary artery disease. Now, I promise you, the cardiologists have discharged me, and yeah, they don't want to do an invasive test with 1% risk of stroke on me every year. But if they had something like OCT for the heart vessels, they would be doing that every year on all of these patients. So we're lucky in ophthalmology and optometry. We've got a transparent organ we can measure well. Now, in years gone by, people used to say, do we care about pre-parametric glaucoma or not? The point being, well, if it's so mild that it doesn't affect people, maybe you shouldn't care about it. But that was in the day where they didn't have OCT, and they would have to look at this and decide whether someone was getting worse or not. No wonder they would rather wait till there's a visual field defect, which we had a tool to better look at progression. And of course, OCT has given us this. Not all OCTs. This is the Zeiss Cirrus OCT, which we use at Moorfields, and it's often all over the place. I'm not sure how well we can look for progression on this. And you think, yes, this one, they've got progression, but actually no, the latest scan was the thickest one. So it's often very noisy and all over itself. So, one of the reasons I wanted to work at Clinica London was that we've got the Heidelberg Spectralis, and that's just complete, it's night and day. It registers according to anatomical landmarks where it's going to scan. And we know with the Heidelberg, it scans and scans and scans again. It does so many scans and averages them to reduce the noise. And then that's beautiful. This is just a diagram showing that if you scan in a slightly different area, it can look as though you've got progression, or it look as though things have changed even though they haven't. You can look at visual fields. In the interest of time, I won't talk about this, but visual fields, even when they're normal, if you look over time, you could see some subtle changes. But really, the king is OCT for looking in earlier changes. This was a nice study that showed it, that actually in early stage disease, you're very much more likely to pick up progression on the OCT. And here's an example of that. So this patient remained with a normal visual field, but actually lost an awful lot of nerve fibers and started to get glaucoma on the OCT, which you could see very easily and very quickly on OCT, but not on visual fields. But remember what Minak said, that you can get a floor effect. So once you've got bad glaucoma, the OCT will look as though it's not getting worse on the graph on the left there, but the visual field takes time because it's so noisy, but can show progression over time. So a few cases. This is a 59-year-old woman. She's wheelchair bound. She has autonomic dysfunction. Her father had glaucoma. Pressures were slightly higher on the right than the left. Visual fields completely full. This was her right eye. Normal, this is the Brooks membrane opening minimum rim width compared to a normal reference database, looks normal. A circumpapillary retinal nerve fiber layer, not bad. I'd like to know what it was 5 years ago to know for sure. Then this is the left eye. Oh, is it a little bit thin at one part there? And this is the bit there, is there a slight difference? Well, we don't know. So then you look over time and you use an OCT machine that's very good at looking over time, like we have. The gray line there is where the baseline is, and the black line is the latest scan, and looks as though the BMO scans dropped there. And when you plot it out, it certainly looks as though it's dropped. Ignore the line of best fit because it includes the points that I'm shielding from you now. Same with the circumpapillary retinal nerve fiber layer. It has gone down there, and certainly when you plot it out, it looks as though it's gone down. The other eye, though, the eye with the pressure of 18, looks quite similar there, horizontal, looks quite similar there, and horizontal. And so here, the eye with the pressure of 22 is slowly getting worse, and the eye with the pressure of 18 isn't. And this is OCT progression. And that gave me the mandate to discuss with her, shall we treat you? She had SLT in her right eye, selective laser trabeculoplasty. The pressure came down nicely. And then since then, she's leveled out on both scans there. And the left eye continues to be horizontal, so we haven't considered starting treatment there. So I think something that's changed, I would say, in the last 5 to 10 years is how good OCT is at looking over time. So you can confidently know before, and I should say her visual field, she never got a visual field defect. And so the changes that you see in the early stage, it's all on OCT, and it can give you confidence to not treat, like her other eye, or confidence to treat. This 55-year-old man with a left glaucoma suspect, high myopia, his father was blind from glaucoma, but I asked him to find out it was glaucoma with high pressures, and his pressures were within the normal range, and his the left eye had lower pressures than the right, but that was the one with the suspicious optic disc. So this is his right eye, doesn't look too bad. That's the left eye, it's suspicious. So what do? We follow over time with a good OCT. This is the right eye. It's pretty much tracing over the previous scan there. And look, I think you can be very confident that that eye is okay. Left eye, actually, both on the minimum rim width and on the circumpapillary retinal eye fiber, you can be quite confident it's going faster than aging. So actually, the reason the left eye looks asymmetrical to the right eye is slowly, over quite a few years, it's been losing nerve fiber more, and that's given us the mandate to treat. Just to say, the visual fields remain normal. So if you want to pick up change in those early stages, you need to do OCT. We discuss things. SLT works better in higher pressure, but with him, we've decided to try SLT first, given its convenience.
So my question is, because we know that there's an age-related decline in the OCT-RNFL, if both the left and the right eye showed some decline that was quite symmetric, would you then be more reassured, assuming the visual field was totally normal, just to ascribe that to the OCT age-related thinning? And how much would you say is normal age-related thinning over time?
Luckily, it plots it for you.
Okay, perfect.
And so you compare to the slope of the green line, and that was quite a bit faster than the green line, and the 95% confidence limits were even that tight on it. So sometimes, if you're unlucky and the readings are all over the place, you might not be so confident.
Okay.
Yeah. But you can see when you've got a great OCT and the scans have been done well, it makes those decisions quite a bit easier.
And I'm just curious for Emma and Minak, because I've worked with very different glaucoma specialists who have different thresholds. Would you say that you are also using quite a similar threshold to Anthony in terms of picking up very subtle changes and acting on them earlier? What do you think is the culture from where you work and where you trained?
Yeah, so definitely. So OCT scans are, as Anthony says, the new black. We look at the optic nerve head on color photographs now to see if there's disc hemorrhages, but it's really the OCT scan that we're going from for assessing the actual health of the optic nerve. And I was going to say something else, but I can't remember. Maybe it'll come back to me. I'll pass it to you.
Yeah, similar. So I think the advent of having diagnostic hubs is really useful. So you can get a lot of patients supposedly stable, or at least even if they're borderline, you can see them, you can map out loads of scans, and then you can pick it up, whether they're having early changes or not. So that's been very helpful for me in my practice.
Do you find that patients can sometimes be reluctant to treat without being able to show them a visual field defect, or do you find that as long as you explain to them that these changes are happening, that they're quite willing to go forward?
I think there's progression analysis, which Anthony's shown with those lines showing downwards. It's pretty self-explanatory. You can show them that things are declining. So you can highlight, like, even though actually your functional test, which is the visual field, isn't, the RNFL thinning is showing that you've got early changes. And if we don't do anything, then you'll eventually get the visual field defect.
I mean, you have to lose a third of your nerve fibers before you get a visual field defect. I think that's now become historic. I think we're in a new era, and to wait for visual field defect is I think probably negligent. But for all of those patients, it was a discussion. And I have patients who've got worse slopes than that, who will prefer to just be observed. And we work it out. We say, well, by the time, if it doesn't speed up, then by your time you're this age, then maybe you'll start to get this and start to get that. And some people would prefer not. So, but sometimes I'll finish on this one so that we don't overrun. This patient has pseudo-exfoliation glaucoma, which we know can be really aggressive. She had narrow angles because of the pseudo-exfoliation. They get loose zonules and the lens can come forward. So she's had bilateral laser iridotomies, and then when the angles opened, selective laser trabeculoplasty. But her intraocular pressures were really never above the normal range, and we suspect that they were spiking at other times. I took over her care when a colleague of mine retired from private practice, and unfortunately, her left eye did not do well. I think she was seen by somebody else, then the person before me, and then me. And really, her left eye has poor vision. It's a very poor outcome. Sadly, that is sometimes seen with pseudoexfoliation glaucoma. But her right eye seems fine, right? If you look at just the visual fields, there's no slope there on the mean deviation or on the pattern standard deviation. So what's happening with the OCT? We know if we want to pick up early glaucoma progression in her, that we won't pick it up on the field, we'll pick it up on the OCT. So this is the OCT. That was this retinal nerve fiber layer. This is the minimum rim width. Quite a lot of change. That's what the scan looks like. And that's on maximum tolerated topical drops. So that's the retinal nerve fiber layer. That's the minimum rim width. So not only will I offer a medical or laser treatment to a patient with pre-parametric glaucoma with a full field. This is a lady with an only eye, with a full field in that eye. But I mean, that's undeniable. I've got the advantage of, with her left eye, we saw what happened, and that's pretty horrible. And we don't want the same to happen to her right eye. So I operated on this lady, and for now, thankfully, it's leveled out. But I think now we're sort of, with good OCT, we're really better understanding the earlier spectrum. And I think that we can even warrant even treatments like surgery. And just to point out again, you know, if we waited for a visual field defect in this lady, I think it would have been the wrong thing to do.
Yes, and there is one quick question, and it's sort of related here. It's, can you explain BMO and the significance of it?
No. So BMO is Brooks membrane opening. And essentially, one of the problems when you're trying to measure the disc and you're trying to measure cupping is what's the reference plane. And so when Heidelberg, the previous device, it was the Heidelberg, the HRT, the Heidelberg retina tomograph, and it used to just take the height of the disc at the temporal margin as the reference point. And the problem is it can really vary, and especially when you've got sloping rims. If you take the reference point up here, it would look as though they've got a really big cup. If you go down here, it would look as though they've got a small cup. So it's about that anatomical consistency and also consistency between patients. And it turns out, after a lot of research, that the opening in Brooks membrane, which is the membrane, the deepest membrane in the retina, is the most repeatable and easy to measure over time. You look at that, and they looked at lots of different measures. Well, what if we do the vertical, the horizontal? And they found the one that best predicted who's going to have visual field loss was the minimum rim width. So it gets, the OCT marks out where the rim is, and then from the edge of Brooks membrane, it draws what's the shortest line I can do to get to there. And the reason we use it is just that some research has shown that that's the one that best correlates with glaucoma and functional glaucoma loss. This is something that's coming up. I mean, it's not available yet. It's going to be available on Topcon devices, actually, called Rota, which from a standard OCT scan can give you these maps, and you can see in the top right there these beautiful visual field defects. And patients that we previously thought were ocular hypertension actually all have retinal nerve fiber layer defects that we're missing on OCT. So watch this space when it comes. Thanks for your attention. And if you have any other questions, you can always email me. Thank you.
Thank you. That was really insightful. Okay, and next we have Emma. We're looking forward to these cases. She came up with the very witty Mince PI. Mince pie. And so we do have mince pies here for all of the people that are with us today, joining us. Please have some in person. They're on the table. Okay, go ahead.
Thank you. Thank you. So this is just like two very simple angle closure cases. And it's a little bit, we're going to do a bit of spiral learning because we're going to go back over some of what we've already heard. So off we go. That's my name. So we've got a gentleman, Mr. SS, so an elderly gentleman, very high hyperope, +11 and +10. So immediately, what are you thinking when you're seeing that? Is that sort of ringing alarm bells for you? Small eye, yeah.
Small eye.
Mm-hmm. Yeah, and Minak showed on one of his slides the criteria for PAX plus. So immediately he's sort of like he's possibly like a plus patient because he's a high hyperope. So he had his PIs a while ago in April 2018. And interestingly, at that time, they also did a treatment called argon laser iridoplasty, which was quite popular at that time. It's interesting how these things go in and out of fashion. So there was a paper, a very small group of patients, and the results were never reproducible. So we did it at Moorfields for a while for angle closure patients. We couldn't get the results that the person in New York had got when he wrote his paper. So anyway, he had bilateral argon laser iridoplasty, which was quite fashionable at the time, probably didn't really make any difference to his angles. And then the left eye had unfortunately developed geographical atrophy and loss of vision. And the right eye has a little bit of drusen, but nothing. So he's got only eye now. And his daily living's become more difficult. So he's got cloudy vision because of cataract developing in his right eye, not on any glaucoma drops, and pretty fit and well for their age. And these are the visual fields. I have put them around the right way. Yeah. So you can sort of see the left eye has sort of, that's actually from his geographical atrophy. It's got like a lot of visual field loss. And if you're making a decision about doing cataract surgery in this patient, can you see something there that would sort of like indicate how, if you were going to get any improvement for this patient, other than you're expecting them to get some improvement because of their age, but is there something on the fields that's sort of demonstrating to you that they probably will have a good benefit, even though it's their only eye?
The visual field, not the very bottom, the one next to it, that is reduced, and that reduction is most likely because of cataract.
Yeah, exactly.
That's the second graph.
Yeah.
Yeah, so that would indicate that the cataract is reducing the visual field, so it's probably benefit somewhat.
So visual fields are actually, for glaucoma patients and for lots of patients, we've got an advantage when we have patients who've got cataracts and they have glaucoma as well. We've got visual fields in them which show the total deviation and their pattern deviation. So we can say to them, look, this is probably what is going to be the improvement for you. And, sort of if they've got a guarded prognosis, we can say, look, this is because of your glaucoma or your geographical atrophy or whatever. You're not going to have perfect vision if we take out the cataract. So we've already got sort of really good sort of like indication of what's going to happen with their cataract surgery. Even though, to be fair, in a patient who's +9 and +8, we do worry about operating in patients with those kind of eyes. Terrible picture, sorry, so we'll go on, but their nerve is healthy. So this is sort of interesting in that when we see people with sort of high hyperopia, we always worry that they've got a tiny eye. And actually, I can't even read the pharmacy that I've got there. But I remember this one's got a huge lens that's going to go in their eye, even though on their OCT scan, look, they're not even, oh, sorry, I thought it was a pointer. They're not even particularly narrow. So it's just the proportions of their eye, the curvature of the cornea, and the length of the eye, that's why they're a high hyperope.
The iridoplasty.
I think it was the iridoplasty. I don't know. From the audited results from iridoplasty we've done before, I'm very skeptical about iridoplasty, but yeah, I don't think it would be a miracle, wouldn't it? But anyway, yeah. But we do worry about these very small eyes because the risks go up when you're operating on eyes under 20 millimeters. So sometimes they can have just a small sort of back chamber, but sometimes, or small overall proportions, but sometimes they've got very thick sclera and choroid, and then they're at risk going into something called aqueous misdirection, which is a horrible thing. So yeah, which is very difficult to treat. So that's something that we have to warn patients about, and it is a difficult decision with an only eye patient with a high hyperope, whether you operate on them or not because of that risk. So yeah, so everybody's different, and yeah, you get these extreme cases. So that was one. Yeah, so I think we talked about the iridoplasty a little bit. It's still used in some cases. So there's a particular condition called plateau iris. It's very, very uncommon, but it's a particular type of narrow angles. So so you can see it when you put on the gonio lens, and actually you can see it when they have an anterior segment OCT. And the diagnosis of plateau iris is made after they've had a PI. So some people can look like they've got it, but you know, to warrant doing iridoplasty, they'd have to still have the narrow angle and that particular configuration after a PI. So sometimes we do it then, sometimes in acute angle closure. So sometimes we would it's very, very uncommon, as Minak said, to get acute angle closure. So Moorfields is, you know, one of the few hospitals now that offer an eye casualty service out of hours where you can walk in. So patients come from all over. They come from Essex, all over Watford, because they can't access emergency care in their local hospital out of hours. So you're getting a huge population coming with emergencies. And unfortunately, angle closure does tend to happen in the evening. Because that's the perfect sort of time when your pupil is going to be mid-dilated and it's going to touch on the lens. So it does tend to happen out of hours. And we audit it regularly to make sure that we're treating patients well. And it's always about 30 patients every 6 months for literally the whole massive area of, it's probably the whole of London. So it's very uncommon, which is good. So anyway.
So just to build on that, one of the questions in the chat was, is the LPI still used for plateau iris syndrome?
Is iridoplasty?
Yes.
Yeah, after an iridotomy.
Oh, sorry, iridotomy.
After iridotomy, if they've still got plateau iris configuration, yeah, you can do iridoplasty if their pressure's high and the angle's looking narrow.
Perfect.
Yeah. And then Mr. BG. So he's 90 years old, and he's an ex-journalist, and this gentleman is amazing. So he's like, all he wants to do is play tennis. So he's like, I think he's fitter than me, and that's what he wants to do. So he has got mild amblyopia in his left eye, a little bit of drusen, but his vision's pretty good. But he does have a closed angle. I think I've got his scans to show you, but he's got no PAS, no pigment on his trabecular meshwork, and his discs are healthy. So what would you do for this gentleman? What are you thinking? He's got closed angles, normal pressure. He's 90 years old.
So the comment was, wait for symptoms.
Yeah.
Lens extraction. Cataract surgery is mentioned on the chat.
Do genetic testing. He's playing tennis at 19.
It's amazing.
Super.
He is, like, if you saw him, he's just unbelievable. Yeah. He's got good lessons on life as well. So yeah, I think his positivity has kept him there. Yeah. So yeah, he's got symptoms. Yeah, so he doesn't really meet the plus. He doesn't meet plus, does he, to have iridotomies? But it's just whether he wants to have his lens taken out anyway to improve his vision. So that's his options, either just to watch him or whether he's getting symptomatic from a little bit of cataract, whether to take the lenses out, and that's up to him. And the thing with angle closure, when you're taking out the lens, really we should be calling it clear lens extraction. And I've been in theatres before now, and sort of we've got the consent form saying clear lens extraction, or they're on the list, and you know, the staff are going, what on earth is that? What's a clear lens extraction? But it's just cataract surgery, but we're just calling it a different name because we're differentiating that we're doing it for angle closure rather than for vision. So if you see somebody's had clear lens extraction, it's because they've got, that's telling you this because they've got angle closure. Yeah. So this is his biometry. And interestingly, he does have quite a shallow anterior chamber, even though he's got a long eye. But then your lens gets bigger as you get older, doesn't it? So yeah, so he has got quite a shallow anterior chamber. And the other thing to say, because he wants to play tennis, this is, even though he's a bit amblyopic and stuff, we do put extended depth of focus and multifocal lenses in patients who are the right patients for that. I know you do lots of multifocals and extended depth of focus. You know, this patient, when he does have his lens removed, he's going to have an advantage then that maybe his tennis play is going to get better if he wants that extended depth of focus. And he's kind of, he's not sure because, his competitiveness, he's actually thinking maybe he wants that advantage with his tennis playing now, and to have his lenses taken out. He was looking at all the websites, and then as he's a journalist and thinking, oh, this is an opportunity for me now. So, very nice man. So what is your plan, which we've kind of talked about? And scale of primary angle closure glaucoma, just to say, I think we've talked it down a little bit about the risk of going into acute angle closure, but it's still like a cause of vision loss. So, you know, the patients, you want to pick up patients and you want to treat them appropriately. And it's a problem, you know, for European people as well as for, you know, the Asian sort of population that got sort of smaller eyes. And the primary angle closure definition, which Minak, I think you covered this a little bit, isn't it? So we call PACS if it's in apposition for more than 180, but primary angle closure, you've got to have some sign of damage, basically. So that's your damage is either because you've got pressure, or you've got damage because you can see damage in the drainage channel or on the iris, and then goes on to glaucoma. And then management in the community. Sorry to show you this slide again, but Minak showed you this slide before. It's difficult, really, sort of anticholinergic medication, because so many people go on anticholinergic medications, like even antihistamines have a bit of anticholinergic action. Flu remedies, it's tricky, isn't it? But to have knowledge, I expect, is power. So if you know you've got narrow angles, you're going to avoid all those high strength sort of flu things come Christmas time, to sort of avoid that risk. And that is just the two big trials to mention. You may hear this EAGLE study. So yes, you've heard of the EAGLE study, and that was for people who definitely had damage. Clear lens extraction was advantageous to doing a peripheral iridotomy. And then the one that we've all mentioned, the ZAP study. So there are these nice pictures that a colleague of mine, Rashmi, did. So infographics on different trials. If you look them up in Eye, they're kind of nice to put up around the place. They kind of explain what the trials are in a palatable fashion. And that is it.
Thank you. Perfect. I have one quick question here. For patients who might have posterior segment issues, so they come in, we're worried because they have lots of new floaters, some flashes, but the note has said in the optometry office, narrow angles, and they're not going to get in to be seen. And so what do you suggest for the optometrist who's in this position, worried about their narrow angles? Can they go ahead and dilate for an issue like that?
So, yeah, what would I say? So I think it's safest to dilate them in sort of a place where they've got access to pressure lowering medications if their pressures go up. Like if you're going to dilate somebody in a hospital or in a clinic setting, that's kind of the safest setting for them to be dilated in. And you would do a gonioscopy beforehand. And usually you can get like a view of the nerve. If you saw they had hideous glaucoma, high pressure, or like a really terrible looking drainage channel, then you're going to wait and you're going to do an iridotomy and probably just do a B scan first to see if you can see a tear.
Optos as well.
Optos, yeah, Optos, you can often get a good view, Optos and a B scan. But usually you can dilate people. It's very rare that we wouldn't dilate them.
I mean, in the ZAP trial, there was over 700 people in that study. And what they did is they got people with narrow angles and they did laser in one eye and not the other eye. And in every study follow-up visit, part of the study protocol involved dilating their pupils. So they've got a study, and the rate of angle closure following that was extremely low. So even with putting dilating drops in people, and that's because they had both eyes done. So the eye that didn't have laser got dilated. So it is actually quite safe. And I completely agree. You know, actually a posterior vitreous detachment is one of those times where if you get in quick enough, you can really save sight. So that ends up being more important than the very small risk of tripping into angle closure. And then if they do, you've warned them anyway and they can get treated.
Yeah, so they'd know then. Yeah.
You know, with dilating eye drops that we use in practice, I usually tell people to look out for symptoms in the first 48 hours. Is that good enough? Because when the pupil goes back to normal, we go back to the normal risk with the angle closure.
Yeah.
So is 48 hours a good number of hours to because I don't want to worry them forever because they've had a dilation. So I just said in the next 48 hours, if you have any redness, pain, blurry vision, report back to us or go to the hospital. Is that good enough?
I think so.
48 hours.
It sounds very sensible.
You normally use tropicamide 1%.
It should be less.
Yeah, I know, but I just tell them
6 hours.
So if they're going to get an attack if they're going to get an attack of angle closure with tropicamide 1%, let's say, which is what we use in the practice. So I just say for the next 12 hours. 12 hours. All right, thank you very much.
Okay, are there any other questions? Oh, there is one online here. Would you consider giving atropine to narrow angle patients with a very short axial length post phaco? I can read that one more time.
Okay.
Nice and slow. Okay.
Yeah.
Would you give atropine to a narrow angle patient who has very short axial length post phaco after cataract surgery?
I think you can argue it either way. So yes, so some people do because it can help prevent them going into this malignant glaucoma. But some people say no because you're just delaying the inevitable. But maybe you delay the inevitable once the cataract surgery is settled down then. So you can argue it either way. Yeah, there's no trial on that. There probably never will be. So, yeah.
Yeah, I think the few cases of aqueous I've seen, often if they end up being on atropine, I found that when the atropine comes off, they go back into aqueous misdirection. And ultimately, the most definitive treatment is quite invasive, and that's often a vitrectomy for these patients if they're having persistent aqueous misdirection. I guess if a patient's had aqueous misdirection in their contralateral eye and I'm operating on their eye, perhaps I would maybe give them a drop of atropine at the end of the operation.
Okay, thanks so much. Okay, so that was it. Thank you so much for such an expert panel to come together around Christmas time, and for all of you that have joined us from in our Clinica space, our little space here, and from online. We were happy to get lots of feedback, so that was great. Thank you so much. We hope everyone at home has a really lovely season. We have clearly a really expert group of glaucoma specialists working together at Clinica, and it's so nice to see the way that they collaborate and the way that we can all speak together. So we're always happy to see your referrals. And that's about it. Thank you so much, guys. I really appreciate it.